Thank you for joining us to talk about dramatic improvement in patient satisfaction at Memorial Hermann Hospital System. My name is Tammy Remmert, and it is my pleasure to be your moderator today, and I will help you with any issues or concerns that you may have as you interact with us today during the webinar. Over on the left-hand side of the web interface, you'll see the presenter screen kind of illustrated here. You can resize this by clicking and dragging on the lower right-hand corner. And on the right-hand side is the control panel where you can adjust your sound and interact with us. If ever you have any issues of a technical nature or have questions about the presentation, simply key them in this little box, click send, and either myself or someone will be sure to respond to you. For questions about the presentation, we will compile those, and at the end of the webinar, answer as many as we can on air, and for those that we don't get to, we will be sure to follow up with you after the webinar concludes. I want to tell you a little bit about Beyond Philosophy. Since 2002, Beyond Philosophy has worked with leading organizations around the world from our offices in Atlanta and London. Specializing in helping organizations to create deliberate and emotionally engaging customer experiences, we are constantly pushing the envelope to develop new approaches to measure and drive value in company-customer relationships. Just a few logos of those that we've worked with over the years. And before we get started, I'd like to introduce your speakers. We have Rhonda Dishongh, who is the Director of Customer Experience Design at Memorial Hermann Hospital and has worked for 25 years with many departments and organizations who have had little or no results in employee and patient satisfaction. On a daily basis, she enjoys working with patients, customers, physicians, and employees on their self-motivation to achieve desired results. And then we have Qaalfa Dibeehi, who is our Chief Operating and Consulting Officer here at Beyond Philosophy, and he has 18 years of senior level experience in customer strategy and has earned master's degrees in international business management, statistics, psychology, and health administration. Qaalfa's focus is on the business implications of customer experience, especially the overlooked impact of our subconscious and emotional experience on business value. Today, both Qaalfa and Rhonda will share with us some insights that should inspire you and get you thinking about ways you can enhance your own organization's customer experience. And with that, I'll turn it over to Qaalfa. Qaalfa?
So, again, we are just talking about a case study from Memorial Hermann, a large hospital system in Texas. We'll get into that in just a moment. And we're pleasure to have Rhonda, who effectively drove this program. And enough credit can't be given to her. I mean, she's really responsible for all of this. These are the learning objectives that we want to get through, and I guess just to preempt all of this, just to say what you're going to hear today was not the result of a large Memorial Hermann team of enthused people. We really started off with a really small team, and in the initial stages when we were there initially, it was effectively 3 people. One of those persons is a kind of executive administrator, and then we had 2 people who were really in the field getting it done. So the point here is some of the results that you're seeing today came about not because of a large resource effort. It came about because of dedication of Rhonda, essentially, in that. Okay, so the first thing is about Houston and the market that we were dealing with, and I think many of you who may have similar situations, but Houston, a very hyper-competitive market in the healthcare, since many of you may have heard of the Texas Medical Center, very large center of many number of institutions, lots and lots of patients. People travel internationally to get there, and within that you have some of the world-leading institutions. So just thinking, when we started this out, we were looking at Memorial Hermann's cancer service line and also their heart and lung service line. If you think about some of the world-leading institutions in Houston that they were competing against, you can see that there is a large weight on the shoulder of this program to kind of get things going. Rhonda, do you have anything on the market, anything else there?
Well, I think what was unique about the market is there are so many different hospitals, and everyone kind of specialized in something, some type of service line. And where Memorial Hermann found ourselves in 2005 is that although we provided great care, our market share out there was small because we weren't known as the expert in anything, and so it kind of left us as a neutral party in the competitiveness of healthcare in Houston. So I think that's kind of what drew our disadvantage and really pushed us into making some kind of changes in an organization that had been around for 95 years.
And I can add to that, at the beginning, because we started this off, it's not only that you have Memorial Hermann had that position, but if you talk to the employees initially, they all pretty much accepted that Memorial Hermann was going to be and also ran in these service lines. Like it was not going to compete really with MD Anderson. It was not going to compete with some of these other hospitals. And so in a sense, a little bit of the we accept our position, and that position really was not what management had in mind for the institution.
I absolutely agree with that.
Yeah. Memorial Hermann itself, when we're talking about Memorial Hermann, it's not a hospital. It is a system, and a very complex system of some world-leading sort of well-known institutions. Many of them you've heard. I think even there was a TV show at one point about part of Memorial Hermann. It pioneered life flight. And as a matter of fact, I'll just say, when we were there, this was 2005, just as about the time, well, it was at the time when Hurricane Katrina hit New Orleans. And because Houston is relatively close to New Orleans, there was lots of activity basically saving patients from New Orleans and bringing them into the Memorial Hermann Hospital system. And I just point that out to say, number one, it gives us a date stamp. But number two, here's a program. This kind of shows a little bit of the vision that I think Memorial Hermann's management should get credit for. During this crisis, when you could imagine that they could put everything on hold because of the severe nature of what was happening at the time, this program kept going. And so a lot of the things that you're looking at, we will be describing, was happening at the same time as all that stuff that was happening in the news, and Memorial Hermann playing a major role in sort of bringing in patients into Houston through that service. So what was the problem? In 2005, the situation we walked into, what we were asked, look, Houston is a large city. About a third of the city are uninsured. Obviously, hospitals want to retain insured patients. So what can we do to keep the insured patients? We already mentioned the hyper-competitive market. So as a result, Memorial Hermann was saying we need to do something to try to retain our insured population. So the real problem that they were shooting for was loyalty, especially of the most profitable patients. Of course, Memorial Hermann has to provide service to patients, and they were not looking to cut anyone out, but they certainly wanted to retain the insured patients at that period of time. Now, the situation has changed, and we'll get to that in just a little bit later. But again, what they recognized is that loyalty was going to be based on providing a fantastic patient experience. As a pilot, they thought, let's start this and see what we can do with our cancer and heart and lung service lines. So let's try this beyond philosophy approach and see what it does for us. And of course, since then, Rhonda and team there have gone on and customized it and taken it to further heights. Rhonda, anything there?
I just want to say about the problem itself. It wasn't real evident, especially not to the frontline staff, and that was obviously part of the problem itself, because volume we had lots of volume. We were very busy, but in healthcare, obviously, some things are more profitable than others. The money's not in diagnosing someone's problem, it's in treating the problem. And then what we were known for, of course, was trauma with life flight, et cetera, and we didn't necessarily have, that's not necessarily profitable business either. And so it wasn't volume, it was that once we had diagnosed the patient with a disease like heart disease or cancer, they sought their treatment other places because those other places were seen as the expert. Although we had the same expertise, same equipment, same capabilities, it wasn't known, even sometimes by our own employees, that we had that ability to do it. And it was, like Alpha said earlier, very accepted by our employees that we didn't need to be the expert in everything, that as long as we were busy, we were fine. But translating that busy into actual profit was where we really struggled, and that's why that's kind of where the problem was and what drove us to looking for something different than just drawing in volume.
Great. One of the things that we walked into when we first walked into Memorial Hermann, they'd already understood that what they were shooting for was not simply best clinical care in a straightforward fashion. They also need to look at the emotional experience of its patients, and they had this pyramid that you're looking at now. And we had some interesting discussions earlier on, and it's always became kind of an inside joke because we at Beyond Philosophy often talk about a customer experience statement. And Memorial Hermann said, yeah, we have something like that. And we challenged them on it to make sure that they really meant what we were looking at in this pyramid. And in the discussion, you said, look, we don't care what we call it. We could just call this Albert for all it's worth. This is what we're shooting for. And we were very satisfied because this also, if you look at it, not only has clinical sounding components to it, but it also has these emotional components to it. So it had things like genuine, personalized, collaborative, comfort, and so on. And with that, we were satisfied that they were taking the full patient experience, which includes the rational and the emotional. So this Albert became a guidepost for all the things that we were developing, or going to develop in this pilot program.
Albert actually is probably the thing that took us to the next level. We always thought that if we provided quality care, it would be seen as quality care. But we didn't realize that the emotional piece in that is if you provide quality care and not the emotional experience, then what happens is the patient still doesn't have the confidence or doesn't have that trust. And so you expend a lot of effort with really no outcome.
Absolutely. So where were we at that time? If you think about healthcare in general, you get a kind of view, and by the way, this is all based off of Pine and Gilmore's Welcome to the Experience Economy, but if you apply that to the healthcare sector, you kind of think about the progression of dealing with patients. And at the base level, what you're doing is treating obvious symptoms. As you move up a notch, it's kind of like you move from the symptoms to the disease, but effectively you're looking and treating the illness. At the higher levels, and this is where most people would probably nod their heads, say, yes, we agree with that you're moving towards treating the patient, patient-centered care and that sort of thing is where things starts to come in. You start to moving from the illness to the person. And at the highest level, you have managing well-being. Well, the transition for many institutions is to try to get from treating the disease to treating the patient. So all the things that we're talking about in that Albert with best clinical outcomes, but also including the emotional space, means moving from or crossing from that barrier of illness treatment into the person treatment. And of course, I think Memorial Hermann has kind of taken things and have gone into the manage the well-being. So the whole point here is you have to get into differentiated emotional engagement, and all of this affects long-term health outcomes. And that's kind of the game that we were going to. So the transition for Memorial Hermann was to get from and cross over this line into treating the patient. In order to do that, it requires a focus not only on the clinical, which they had and were fantastic at, but also including the emotional engagement.
And along with this, the question I get the most often is, how did you get the clinicians, how did you get the nurses and doctors to buy into this? And this was actually what was probably the best selling point to them, is not this graph itself, but showing them or getting them to hear that patient tell their story, that treating the disease gets the patient out of the hospital and gets the patient home, but then they return with the same disease, and we label them as non-compliant. It's a non-compliant patient. But through the different way of thinking, because it's not about the initiatives that you're implementing, it's truly the different way of thinking. And through that different way of thinking, what we learned was that if you had a patient that was satisfied, and however you satisfied them, then they were more likely to be compliant, which meant they would have better outcomes. Well, convincing those doctors and nurses became just a point of showing them that their success isn't based on diagnosing a patient, but it's based on the final outcome. And when you can get a more compliant patient, they have a better outcome and everyone's really more satisfied. So it was really about, you know, satisfying their need as a caregiver or a clinician to truly have that impact on a patient.
Exactly, and this has been further verified in recent years. Those of you who are in the sort of hospital area and healthcare in the States will recognize HCAHPS shorthand. Patient satisfaction becomes important. We'll talk about this in just a moment, but effectively the government is starting to pay attention to patient satisfaction, and if you think about some of the things that they're asking about, they're really getting at person treatment, not just illness treatment. So it's becoming important for the government. If you hear all the debate, if you're in other parts of the world, in the United States about healthcare reform, effectively the government is stepping in saying, yes, we actually do care about this person treatment side of things, and so that the whole movement is towards looking at this person treatment. So Memorial Hermann essentially was ahead of the game by the time this came into play, and we'll talk about that in just a moment. What did we do at Memorial Hermann? This is, I guess, the crux of things. If you're looking at the top here, the tools that we used in this initial pilot, something we called customer mirrors, moment mapping, and pyramid, which we'll briefly highlight. What we were trying to do is understand the end-to-end patient experience. They wanted us, and we wanted to redesign the experience that they were providing. Again, redesign with that emotional engagement also in mind. And then, of course, we needed to get employees to buy in. We mentioned where we started off with employees, and that they were thinking, look, you know, we are where we are. We have this competition, this world-class competition. You know, we provide what we provide. They provide what they provide, and you know, we're doing a good job. We're all providing excellent clinical care. So really, what more can you ask of us? So there needed to be something which really excited, achieved buy-in, and was actually going to get some behavioral change on the part of employees to actually do something different. Because you have to imagine, think about physicians, people, nurses, people highly trained in their fields, years of experience doing things whichever way they were doing those things, and now you're coming in with something that's going to suggest some change. Because obviously, if no one did anything different, then certainly you're not going to get a different service. And we were talking about redesigning the cancer service, redesigning the heart and lung service. And so those things were important. What you see on the right-hand side, emotional signature, some of you may have heard of us talking about this. In 2005, we were just at the beginning phases with emotional signature, and again, showing a bit of the vision that Memorial Hermann had. They were one of the first companies to do an early version of emotional signature. But the key things we're talking about today really have to do with the customer mirror, moment mapping, and pyramid. I just point this out to say that they did go through an early version of emotional signature, but the original pilot really were these three. So, starting off with this customer mirror. The way I like to explain this is we had something, you know, you guys may understand mystery shopping, where you go in, if you want to know, this is the policies and procedures. We'll have a check if you've done what if the employee has done what we've asked them to do, then they get a check. If they haven't done, they don't get a check. So it's a great, mystery shopping is fantastic for checking if the employees are doing what the management has asked them to do. Unfortunately, or the reality is, patients, customers don't know what management has asked employees to do. What patients know is what they expect, what feels right to them. So when we have a customer mirror, we effectively walk the experience and try to look at it from a patient's point of view. So I'll just point out a couple of things here. Imagine you have prostate cancer or some other type of cancer, and you go into the toilet. Number one, you get a sense of cleanliness, And it's not just of the toilet. I mean, you start judging the entire service, the entire hospital, the entire experience based on what you're looking at in the toilet, potentially. The feel of the toilet paper may seem like an insignificant thing, and it's something that probably is below the conscious radar of many patients, but again, that adds to the experience. A lot of things here, and when we talk about these waffle robes, they had some of these very soft, comfy robes, and some parts of Memorial Hermann and other parts not. But again, that difference versus a traditional hospital gown and how you put those on and the places you have to put those things are great signs. So we basically try to look at the experience from the patient's point of view, and everything, no matter how insignificant it may seem. You know, here's a cart. What does that cart say to you? How does it look? Does it look sterile, technical? Does it look like great clinical care? Does it look severe? Does it look important? And so on. So we try to look at the experience from the patient's point of view.
This part right here, the mirror, the customer mirror, when we first started, I would have stood by and told you that I know exactly how a patient thinks because I've been a patient. And this was probably instrumental in just turning us around. And again, it's not about the tactics that we implemented. What it was really about is just a different way of thinking. Even these steps that are the little colored squares in the middle, we said that was the steps the patient goes through when they have cancer treatment. So when we asked the patient what steps they went through, it wasn't necessarily the same. And again, Alpha just said, you know, we judge things by little check marks, but the patient doesn't know what those, you know, what those things are that they're looking for. They just know what they expect when they walk in. So I guess the most valuable part of this experience in working with Beyond Philosophy in the customer mirror was really truly being able to, for the first time, and I've worked in healthcare almost 20 years at this point, was to really truly see things from that patient's perspective and just really change our way of thinking. So again, it wasn't about, you know, start implementing this or saying these 5 words or scripting or any of that. It was really just about looking at things from where the patient's coming from and seeing things differently. And so truly an end-to-end experience and creating that to make us all more successful. And change is hard, but in doing this and seeing it from the patient's eyes, the change was so much more doable because we were getting so much out of it as well. Like I said, for the first time, being able to truly see it from the way the patient looked at it.
Great, and there's Rhonda. There's Rhonda down here. Okay, so that was the mirror. So we did this, and by the way, when we do this, we went to several hospitals, and you know, within the system, you know, there are different experiences as they occur throughout these several hospitals. Some of them were, you know, had some parts which were fantastic. We also did a kind of a competitive mirror. So we actually went to a MD Anderson and kind of had a look at some of the things that they were doing. So we could kind of compare the experiences between in the mirror from the patient's perspective at a Memorial Hermann, several different hospitals, and the competition from those points of view. Okay.
One more thing. That black bag that was in the middle with the little pink feathers across the top, those bags were actually made at one of our cancer centers by our volunteers. And when a new patient came in as a cancer patient, they got so much information and they had so many things to carry back and forth. So the volunteer, who was a cancer survivor herself, made those bags and we gave them out to the patient. But I'll tell you how self-centered we were. We gave those bags out to the patient, and also those certificates at the top of the certificates of, you know, congratulations, you've completed your care. We did those as emotional things, you know, for the patient, even prior to Beyond Philosophy coming in. But what we learned was they aren't bad things, they're great things. And although they were super for some of the patients, emotionally they weren't the right things for other patients. And we felt real defensive or offended if they did not want that certificate or if they did not want that bag. We created this for you, you know, out of our heart. You should take this. And we almost wanted to force it on them. But what we found is some people want that certificate to hang up on the wall to say, look what I conquered. Some people are so emotionally anchored with it that they didn't want that certificate around them because they just really kind of wanted to put it past them, and that was their way of defeating it, is to just move on from it. So again, it really helped us see a different way of looking at things that, even when we thought we were doing something to reach the patient emotionally, we were then forcing it down their throat, even if they didn't want it.
Yep. We'll talk about that certificate thing in a little bit when we get to the moment mapping bit of it. One of the things that allows, when you go through the mirroring, what you can do is, of course, you kind of get a picture as we just showed on the previous slide, but you can get a series of these barometers. So think about going through the experience, so the same basic general steps, and you kind of then getting a sense of where are we, in each of these steps. And again, the barometers there can be several barometers. So imagine, this one is about recommend. Would I recommend this experience at this stage? Yes, no, and so forth. And this promoter, passive, and detractor range just kind of follows from, if you guys are familiar with Net Promoter Score, it just kind of follows that kind of thinking. And you can see, based on this experience, a number of things in this detractor range. So not good enough. And in this particular stage, billing was exceptionally low. Imagine another barometer could be trust, could be care, could be safety, could be any number of emotional, engaging sounding barometers, and we could do the same kind of measurement, again, from the patient's point of view. So no matter how many ways you could prove from a system or hospital point of view that you are achieving X, Y, and Z, you can look at things from the patient's point of view and kind of get a quick sense. Now, we felt these were useful because obviously Rhonda and the team had to communicate this back to management. So they had to communicate the results of the mirrors back to management, back to the people who were going to say yay or nay to changes in the experience or to open their eyes up to the experience. So while the pictures are very powerful, you can tell those stories, of course, like most organizations, at a certain point in a meeting when you have your 15 minutes with the board, you have to get across the story very quickly. And so one of the methods we use are the barometers to try to get some of the stuff that we've learned in the mirrors across very quickly.
And in your 15 minutes, this gives you so much power because you do literally have that 15 minutes because you're competing with so many other things. But in our 15 minutes, it was said, well, of course, no one likes to get the bill. I mean, we knew that was going to be a negative experience or a detractor. But then we started talking about the patients expect a bill. They know they're going to get a bill. So is the negative truly the fact that they got the bill, or is the negative the way they got the bill? So it, again, gave us a different way of thinking of things. So they still get a bill, but the bill is no longer seen as a detractor from that patient's point of view.
One of the things that happened, so if you guys recall the Albert, that triangle that Rhonda spoke about earlier that we showed, one of the things we did was called a pyramid. And in this pyramid, it relates to how do we translate that Memorial Hermann System's Albert. So how do we translate Albert into initiatives, things that various functions, various departments within Memorial Hermann can carry out. So imagine you have inpatient, outpatient, nursing, volunteers, the business office, so on and so forth. So effectively what we ran was a large workshop. So imagine each of these tables in a way being a sort of a department at Memorial Hermann. So, different organizations may have different departments, but let's just say this was inpatient, outpatient, another one could be medical records, so on and so forth, whatever they were. And they work through, remember all those elements, those various statements when we showed the Albert. One was collaborative, personalized. So imagine it is personalized. And we have the business office, and we're saying, in order for personalized to become real at Memorial Hermann, what is it that inpatient service has to do? What is it that the business office has to do? What is it that admissions has to do? What is it that the call center has to do? What is it that housekeeping has to do to make personalized come to life? The reason we set it up like this is because quite obviously, if you're talking to, say, some nursing type department, how they see the world, what they're going to do is going to be different than, say, the guys in finance or the people in housekeeping, or the people in the cafeteria, and so forth. So imagine each of these sheets relating to, so let's say these three relate to three different departments. They've worked through what personalized means on this, and it's a facilitated workshop. This occurred over 2 days. And at the end of this, you get a whole host of, here's some things that our department, our function, these are things that we can do to make personalized comes to life, to make collaborative comes to life, to make best clinical outcomes come to life, and so on and so forth. So this was a workshop, and I have to say Ron did a fantastic job of, the whole point of this also, when we go through the project, was to make the actual project itself an experience, to demonstrate to employees the difference, because we could have been very transactional. Come to a workshop, you'll be there for 2 days, participate, and then you'll go back to your regular day job. Rhonda basically made this an experience from the invite on down to the way the workshops were facilitated by us. So this was, it turned out to be fantastic for us because it allowed us to translate the experience that Memorial Hermann said they wanted to achieve, the Albert that we discussed earlier, and it was translated into the various functions and into ways that they would understand and things that they could literally carry out.
On these 2 days, we, as a company or as an organization, we had many ideas, probably 150 different ideas that we came up with in those 2 days, but that wasn't the return on the investment for the 2 days or the return on the investment for the whole project. This is where the whole project that we did really came, we really got our value out in these 2 days, because in these 2 days we had over 50 employees from across the system, representatives from everything that touches the patient. Every one of those people left on that second day not having shared ideas or going back with their ideas that they may or may not implement. What those 50 people left with was everyone had bought or invested in the ownership of this, of creating this change and redesign. So really all 50 people walked away owning a piece of it, and collaboratively those 50 people made it happen. Because we could, as two people in the system, we could have all the great ideas, we could do the mirror, and we could get it. But by these 50 people getting it in those 2 days and investing in it and taking that away and it becoming part of them, then that spread out through our organization like fire, and that's truly where we got our real return on investment and what truly made the change. Because we had worked on this before. We had worked with different groups before, different things, none of which had the same impact, and it truly was because those 50 people, and I know you use the term buy-in, but I don't think they bought in. I think they actually just internalized a piece of it, and it became part of them, and then just spread out through everyone they touched.
Mm-hmm. Great. So at this point, we have this thing called moment mapping. So we've talked about so there was 3 components to this initial pilot, really, 3 main things. One was the mirrors, which we talked about. 2 were the pyramids, which we just talked about. And then this moment mapping, which I think is sort of the piece de la resistance on this. And what it is think of this like standing workshops. So you have a hospital, busy individuals dealing with patients. It's going to be virtually impossible to literally take them out of their jobs for any length of time to come to a workshop to come up with ideas about things. What we were trying to do here, again, is get them to, as Rhonda say, internalize some of the things, think about the experience. When we say the experience, they clearly understood the clinical side of things. We wanted them to think through that emotional engagement side. And effectively, what we did was this. We have a system of these brown paper, and think about these like a construction site of experience redesign. And we would take this brown paper to various hospitals and various locations. So if we wanted the 5th floor ward, whatever, to participate, we would take the brown paper to them rather than having them come to the brown paper. The whole point was to spread the word, allow people to participate, and open it up to as many people as we could. We pretty much almost literally ran this for 24 hours. Why? Because the hospital never closes, and we wanted to get people from all the various perspectives, whether you work on a night shift or a day shift. We did this in I think a couple of different hospitals, several different hospitals, and we manned it. So within these, we had these brown papers. And again, I think this particular shot was from, I guess, medical records in one of those hospitals. Why? Because it was a high traffic area, and that's where people would come. So we knew that they would just capture them as they walked past. People would just want to know, what is this? And in a very short conversation, you're able to explain, get them engaged, and they spend a few minutes on it. We're usually there for a period of time, a day or so they can kind of come back when they have little breaks. And people become very interested. It's very engaging. And what you tend to get is scenes like this, where these busy professionals just get engaged with this brown paper. What are we asking them to do? Very simply, number one, offer ideas, things that we do well, things we don't do well, things we could be doing, that sort of stuff. But also they get to, in a very quick way, comment on the ideas that are already up there. So imagine if the CEO of Memorial Hermann were to put up his or her idea on this brown paper. It's all anonymous. As staff comes through, they're able to essentially give their vote on a particular idea. And, they may not like it, they may like it. But we're able to pick up why they like things, what it is they don't like. And through this discussion and the way, employees starting to discuss amongst themselves these ideas, again, you get the conversation going around the full patient experience. And people are thinking not just how do we do things more efficiently, but it's how do we address the full patient experience. What you're looking at over here, just to kind of make a point, as we already mentioned, Memorial Hermann is well known for its emergency services, and of course we wanted them to participate in this as well, even though a lot of this was around the cancer service experience. So that's an important point. Everyone was open. We didn't sort of limit it to, if you have nothing to do with the literal provision of cancer service, then we don't want you to participate. This was open to everyone. So we took this around, emergency services is another one, and obviously, they're very, very busy. They're not really even going to go to another floor to go see a brown paper. So I think at Memorial Hermann, at least one or a couple of the hospitals, they have these, I forget what they're called, but these poison control rooms, decontamination rooms, which, in case of a some kind of chemical attack or whatever, they can use those things. So we basically were right next, and we just used those rooms. And the point is, we took this experience, we took the moment mapping to the employees in the same way that we want employees to take the experience that we redesign to the patients.
And again, it is like a construction site. I think that's the perfect example, or perfect comparison. And the reason is because, we have 20,000 employees in Memorial Hermann. And so as you think about that, and I think at this time we probably had 14,000 employees, but when, with 14,000 employees, you're going to have a group that, they really want to participate and they can't wait. Then you're going to have a group that kind of doesn't want to participate. Well, if you could compare this to a construction site, all of the ideas, and even if you didn't put an idea up, just coming and like you said, looking at other people's ideas and commenting, and even if it was a negative comment, it made us think about that idea of, is that real or whatever. But it's almost compared to every person that came in that looked at that piece of paper. If we were building something, it's like every person that came in and looked at the piece of paper nailed a nail into whatever we were building. And then you had some people come back that said, hey, I really enjoyed putting that nail in. Can I hammer another nail in? And so you had some people who might have nailed 100 nails and some people who might have nailed 5 nails, but every single person that walks past that experience or walks in that experience in the future says, I built that. That's mine. That my handiwork is in that. And so all of a sudden you have 20,000 employees that own your cancer experience. So not only are they contributing to making it what you want it to be, but they're out there advertising it across the city to their friends, their family, their relatives, of you don't want to go anywhere. Look what I built here. And so this truly, just like that pyramid workshop, you had 50 people who invested and bought in. This, you had probably 1,000 employees that participated and bought in it.
Absolutely. So one of the things as part of that moment mapping are things that we did. We obviously talked to actual patients and caregivers as well. And one of the things we learned was, in fact, they believe also that emotional well-being is a role for the hospital to play. And again, this was important for us because in redesigning the experience, you could argue, actually, patients don't care. What they would say they care about is just getting better, and that's the end of it. From a clinical, physical point of view. But that's not what we learned. In fact, you're looking at these figures. Almost a third of what they consider to be the hospital's responsibility is to take care of that emotional side of the experience. So again, very powerful for us when we were going about the redesign to take all of that into consideration. And so when we were talking to the employees, at a later stage, or when Rhonda was kind of taking this out and rolling this out, she's not just able to say, we believe. It's patients also believe. Caregivers also believe. We had people who participating in these things. And by the way, some of the people who came to these focus groups, they are not all people who had like the best, the outcome that everyone wants, and that is the all clear, healthy, done. People who had lost partners, other things were part of the focus group. So in essence, this is a normal part of hospital life. Not everyone gets to go home essentially. But what was important, I think Rhonda mentioned this earlier, is that what they cared about is how care was given. And we came up with this patient satisfaction matrix, which is kind of important. And that is, there's clinical outcomes and there's emotional outcomes. Clinical outcomes, I think, most great institutions will seek to maximize, and I'm sure all of them seek to maximize the best clinical outcomes. I don't think that's a stretch for any healthcare organization. What was interesting is what happens when you don't achieve your emotional outcomes, even if you achieve the clinical outcome. Well, satisfaction is at risk. Actual patient satisfaction is at risk. Whereas if you achieve emotional outcomes, even when the clinical outcome isn't necessarily, when I say it's not as what was expected, I mean, because it's a regular part, not everyone gets the all clear. Some conditions just don't merit it. And remember that we were dealing with heart and lung and cancer, so you can imagine what some of those outcomes are like. Even when the clinical outcome is not exactly what everyone would always hope for, if the emotional outcome is there, then they're satisfied. So the main point was there needs to be a lot of focus on this emotional outcome. So a little takeaway is, they may forget what you said, but and they may forget what you've done, but they'll never forget how you made them feel, which is basically a big takeaway. And that's really what we wanted to focus on. Again, we didn't want to diminish the importance of clinical outcomes, but we wanted to emphasize the importance of emotional outcomes. At the end of all of this, of course, through the moment mapping, we had lots of ideas from the pyramids. We had lots of these ideas. Of course, we put this into a project plan and gave that to Memorial Hermann and said, okay, guys, you have to come up with, exactly to put this into play and implement it for your rollout. I want to highlight a bit more. So my main point there is lots of ideas came from it. Some of these ideas are just highlighted here. I guess the concept is about using stories to get across the full experience, and that became a very important part of the solution. So there are a number of ways of going about that, and there are several of those things. So we wanted to see employees and everyone start to think about patients and the patient story as they move forward. And what you're looking at here are kind of manifestations of some of the things that came out of the things that we were looking at. But rather than focus on exactly what some of these are, because these will always be different, possibly depending on which hospital system and your particular circumstances, what are the results? So yes, we did all this stuff. What happened as a result of this? Did we get anything that we were looking for? Well, initially, and this is, by the way, within 6 months post-project, what you can see here are some pretty extraordinary results. As an example, maybe I'll just let Rhonda speak to this.
Okay. The first thing that we looked at with cancer was And we actually learned this in the focus group. We had not realized this until we heard from the patients tell us how long it took from the first time they thought something was wrong until they were actually diagnosed. And for breast cancer, from the first mammogram until diagnosis was 40 days. And when we heard them tell that story and how we contributed to really their agony and waiting for those results, we started looking at that. And what we realized was it was unnecessary. It could just as easily be done in 5 days as 40 days. It took zero change in cost. It didn't take any additional resources, any additional equipment. It just took a change in the way we scheduled patients to move that from 40 days to 5 days. And in best practices, sometimes we actually do it same day or within 3 days. So that was a huge win for us because, you know, just getting that information from them and making that change. Like I said, we're very much seen as the neutral hospital. You know, we could diagnose you, but we weren't the expert at the service lines that actually made money, that had a profit. And before we did the project, our market share for cancer and heart and lung services averaged, depending on which facility, but it averaged around the 17th percent. And now it went up to around 23%, where it's held those gains for the last 5 years. Patient satisfaction, we were already high in patient satisfaction as a system, although we did have some outliers that were in the lower quadrant of the patient satisfaction. Now all of our hospitals are up in the 91st percentile. And even just yesterday, I looked across the system at those scores and saw that we're on the 99th percentile as a hospital system, with only one of our hospitals out of 8 cancer centers falling below that 99th percentile for the year. So we went from being, like I said, that neutral hospital to really being looked at as an expert in that, with very little emphasis on the clinical side at all. Really very little changes in the way we schedule patients, changes in our messages, and really by patients sharing their stories with us, it motivated us to want to become part of that story, maybe in a different way than we had been part of that story before. So it really, the numbers are great. I mean, I'm glad to be in the 99th percentile, and I'm glad that, you know, we are the 23rd percent of market share holder for those service lines. But the reality is, when you work in healthcare and you come in here every day and you do something, whatever you contribute, you do it because you want that patient outcome, or you want to be, you know, you want to have some emphasis on that patient. And that's what this has given me, and I think across the system more than anything else, is that difference, that way of being able to accomplish that, where, you know, before it wasn't that we didn't want to accomplish it, but we were, quite frankly, focusing on the things that we thought the patient wanted us to focus on, but they really weren't the things that were the most important or impactful to the patient.
Exactly. So, I mean, the slide that you're looking at now just kind of highlights some of the specific strategic insights we had and the difference it made at Memorial Hermann. And again, the point in 2005, this is a bit before some of the emphasis on HCAHPS that we're looking at now. So at that time, we were trying to look at loyalty as sort of the ultimate aim, and I think that market share figure shows quite a lot. But again, in the process, we actually cut out costs. So you saw the efficiency thing on the diagnosis and treatment with the cancer service, and there were some other things with patient satisfaction, which again led to some of the gains that they were looking at. The question is, okay, that was fantastic for 2005. Of course, the environment changed since then. Again, in the United States, we all know with the healthcare reform coming up. Many of us are familiar with HCAHPS, so just think of this like patient satisfaction being highly important and kind of being a universal measure of patient satisfaction. So when they look at patient satisfaction, they're asking some specific questions. Highlighted in red are some of those questions. You kind of see a focus on communication, things which basically are in the realm of the emotional engagement, how we would classify that. They're in the realm of emotional engagement. And as a matter of fact, 57% of the questions in HCAHPS are related to this person management. If you remember that graphic we showed earlier up top, that person treatment side of the experience is where we were focused for Memorial Hermann. So one of the questions was, in this new environment, does this still work? The other question was, if Beyond Philosophy is no longer there, did Memorial Hermann replicate any of that success? I'll just introduce this slide, and I'll let Rhonda speak to the next one. Effectively, 2005, there was this hospital that it was called Northeast Hospital at the time. It was not yet a part of Memorial Hermann Hospital system. At the time, it had, basically, it was unprofitable, and you can see a long history of being unprofitable. Basically, a poor hospital, 5% patient satisfaction. So this Memorial Hermann assumed management of it in about 2009, and Rhonda basically went in there and applied these principles and used some of these tools. Again, Memorial Hermann has kind of taken those and Memorial Hermannized those tools, but basically applied those principles to this hospital. And the big question is, okay, if this approach works, what happened at this hospital? So again, you can see a very poor performing hospital. So what happened to this hospital with this as Rhonda put this approach in motion? So Rhonda, if you want to speak to this slide.
Okay. It was actually 2007 when Memorial Hermann assumed management of Northeast, which obviously didn't have a good reputation. It didn't have high patient satisfaction. And so when we came in, really the philosophy of looking at it through the patient's eyes and the mirroring and all of those tools that we had learned how to use, it had just really, quite frankly, become the way we do things, the way we look at things. We apply those across everything: patient safety, quality, operational excellence, and being profitable, growing the business where the business needs to grow, as well as employee, patient, and physician satisfaction. So we use those across, and we've had success in every single one of them. For quality, we actually won national quality awards, and that was in a hospital who had not measured core measures before, and so they really were way behind on what needed to happen. And so to get all that employee buy-in and all of that change during a time of transition where quite frankly, employees were a little afraid because they had been in this individually ran hospital. All of a sudden now they're part of a huge system. So during a time of transition, to see that success and turnaround has been great. And again, our employee satisfaction has just soared upwards because now they're really contributing and they're making that difference. And again, they're being able to fulfill their mission of why they're working in healthcare, because not because they didn't want to do it before, but because they didn't really know how to see it from the patient's point of view. And growth is taking care of itself, because of those other successes around satisfaction and employee engagement and quality of care. That's automatically led to more money, which has automatically led to the ability to grow. And not only the ability to grow, but if you grow services, you have to have obviously people that want to use them. And one of our biggest successes in growth in the last year and a half has been that opening a heart cath, which was a huge investment, but we had the physicians come to us and say, we have such great experiences across the board on these other things. We really want to be able to do our heart caths here too. Well, there's a hospital less than a mile from us that has that service already. Can we really compete with it? But we took that risk and we opened it, and where before in our smaller cath lab we were doing maybe 4 to 8 patients a month. I mean, we're scheduled way out now. We've even extended our hours and opened an additional room in just a year. So really that outcomes, and again, it's not just that we came through and designed a cancer experience. We learned how to design experiences, and we learned how to see things from the patient's point of view and really what's important. Because the clinical is obviously important. Without it, you're not going to have a hospital, period. But it's not what's important. It's only important to the patient if it's not happening, because it's the expected. So that's where the success has stayed. So 6 years later, those methodologies are still being applied every single day across our system, and that's where I think the real success is.
Great. So the main point here on this slide, I won't spend too much time on it, is to say, really, there's 4 questions if you're thinking of trying to do something like Memorial Hermann. 4 basic questions. You know, how do we keep the culture alive? You heard us talking a lot about, I think Rhonda talks about internalizing some of this approach, this way of thinking, understanding really what patients experience. And I think Rhonda mentioned, you know, she's 20 years of experience, or 20 plus years of experience, and really with this approach kind of for the first time really started to think about, have a system to think about what patients actually go through and what matters to them. How does the environment and support this experience, and also what do we want patients to experience? So kind of like the Albert. And effectively, what you get is, you know, you need to understand your internal capacity to deliver. You need to actually redesign the experience. You talked about this moment mapping. You need to transfer the knowledge, and I think you've seen that they have taken that forward, and that's what Rhonda was just talking about. Across the system, they're using these approaches. And then, of course, you need to understand that patient experience. So basic questions there, and there's some tools out there that you can be used, and these things can be replicated as we've just demonstrated, and they work in the current environment. So with that, we will open it up, I guess, for any questions, if there are any, Tammy.
Yeah, we have a few, and we're running a little bit long on time, but hopefully people can stay and hear a few of these questions. Brian submitted one. He said, do you make any attempts to segment patients and deliver different experiences based on different patient segments?
This is always a question about segmentation. Memorial Hermann, of course, had, you know, people use different services, so you could argue that one segmentation was a cancer service line, because, you know, Memorial Hermann could have said, what is the Memorial Hermann experience, period. They had the cancer service line experience, they had the heart and lung experience, and so on and so forth. She just mentioned the cath lab experience and so forth. Now, at the heart of it, there's something central. I guess you can call that the Albert experience. That's across Memorial Hermann, but there is some segmentation. I'll let Rhonda answer this in a moment, but one of the things Beyond Philosophy says is segmentation is great as long as your organization is able to address that segmentation. So sometimes it sounds great to talk about, you know, the inpatient fifth floor ward experience or whatever type of experience. If you honestly don't have the ability to address those various segments, then it's really not doing you any good. So we would say at the starting point, what is it that your organization literally is able to address? For Memorial Hermann, they were willing, able, had the willpower to literally address the experience from the segmented views that they had there.
And I agree with that. Albert is Albert, so your customer experience statement is your customer experience statement. But across your company, different customers obviously are going to have different priorities. So that is your customer experience statement. Your strategies, you know, those things are all your foundation, and so they don't change. However, some of them are more prevalent with one customer than they are with the other. So they're all existent at all times, but you just have more emphasis on some of them. Like, for example, you know, access for a patient who's having an outpatient test is more important than it is to a patient who's having maybe surgery where they're going to be in the hospital for 3 days. Somebody that's having an outpatient test wants to be able to get in and get out. A patient that's coming in to have surgery and stay in the hospital for 3 days doesn't have that. They still want that, but it's not as much of a priority to them as maybe comfort of the facility. So you have those. You always have Albert, but different emphasis depending on what that customer, you know, prioritizes.
Great. I'm going to combine a couple of questions here because I think they're related. Was there any resistance from management, and how was that handled? So knowing the complexity of some of the information that was relayed. And then kind of contrast that or compare that with how much of it has to do with Rhonda, in this case, the person leading the team, versus the Beyond Philosophy approach. So just talking about obstacles and the approach.
I'm just going to lead in, and then, Rhonda, I'm going to open it up to you. When we started this out, as I said earlier, this wasn't sort of a done deal. Of course, there were some visionary leaders within Memorial Hermann, but I wouldn't say that when we just walked out and looked at some of the management at some of the hospitals and some of the people we were working with in the various hospitals were totally into this. We had to build to that. We had to have evidence. I mean, Memorial Hermann was very big on evidence-based care, and obviously if they wanted sort of an evidence-based experience. So just having kind of logical sounding arguments, in a sense, was not really going to be enough. We kind of had to show that things were working. And I can remember one particular person who had the appropriate title, I think it was may have been customer relationship director or a manager at that time, really wasn't into this at all. And so we kind of had to work around that. And there was a lot of work just to kind of get this message out there. A lot of it is just messaging. When I say messaging, I don't necessarily mean emails and so forth. I just mean putting foot to the ground and going out, having meetings, kind of giving these stories, and people kind of have their aha moments at different stages of the game, which is where the pyramids come into play, the moment mapping comes into play, and then you get the effect of those people who have participated in the pyramids and the moment mapping who are able to talk to their colleagues. So we had a whole session on, influencers within the organization. So we didn't want this to appear to be simply a top-down. Management has decided that this is the new experience. We didn't want it to feel like that. We didn't want it to appear like that. We wanted it to appear and feel like the people who are delivering it developed it. And I think that's what happened.
And that is what happened. Different managers were engaged at different levels. We didn't have a lot of resistance. However, the initial investment was made, but then we did have to go prove it. We did have to show some outcomes and show that we were making a difference. And I think one of the ways that we really did that was simply by saying, okay, day one we walked through the hospital, 2 different employees that we spoke to did not realize we had cancer services at that hospital. Fast forward to all of your employees out there telling their story about your cancer services, then you really have proven what you've done, and so they saw that. And again, it's 1,000 nails on that construction site, 1,000 people driving those nails, and everybody that walks past it that has nothing to do with that experience. Honestly, they never treat those patients. They don't even come in contact with those patients, but they feel as though that is their experience that they created, and so that buy-in. So yes, I mean, there was some skepticism, I guess, but we just, went about that by proving it. And I think with those focus groups, once all of us at all different levels saw what our patients were willing to give to us, we were overwhelmed by that. We had patients in that room. We had one lady in that room whose husband, literally, she had his funeral the day before she came to that focus group. And the fact that she was willing to give to us, to share her experience and tell us what's important was just overwhelming. And, clinically, we had one employee that was mentioned over and over and over in those focus groups. And it wasn't a nurse, it wasn't a doctor, it was actually a housekeeper that had created that experience. So really seeing that broke down any resistance we had, and then seeing the outcomes also, of course. As far as is it me versus Beyond Philosophy, obviously you have to have someone who is engaged, who's visionary and who's somewhat influential across, motivational to different people. But I've been in the business for 25 years at this point. I've been in the business 20 years with some success, but not nearly the success as after the engagement with Beyond Philosophy. Because again, truly Beyond Philosophy changed my professional life and probably my personal as well, because with that different way of thinking about it, different way of seeing it, and then having the tools to fall back on to get the information that you need to make that change, to motivate those 1,000 employees to come on, give me your ideas, and not only give them to me, but go out there and do them and encourage your coworkers, et cetera. Really, I can only contribute that to the engagement and work with Beyond Philosophy and their approach. The approach was so different than anything I'd ever seen before, but yet so logical. I wish I had thought of it and that it was all me.
Okay, I apologize to those of you who have submitted questions that we haven't gotten to, but I'm going to go ahead and conclude this webinar because we're almost 10 minutes over time. We really appreciate your investing in your customer experience, and we would invite you to please complete the survey that will pop up on your screen. We do appreciate your taking just a brief minute to tell us what's on your mind and how this webinar may have benefited you today. And of course, we invite you to continue the conversation as you see on the screen here. Thank you so much for attending. We wish you a wonderful week and an excellent outcome in your customer experience design. Thank you.
And thanks Rhonda as well.
Absolutely.
Thank you.